ऑन अभी बात मत करिए। All set? So
Yes, sir.
we'll start. We are live on YouTube straight away. We'll start in a minute.
Okay, sir.
Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 6V, Liver and GI Pathology. And we are streaming live from Gleneagles Global Hospital, Hyderabad via Kolkata. And today we have a special topic, which is a slide seminar on the interesting cases in liver transplant pathology. And to talk on that, we have Dr. Jyoti Dekate, who is a postgraduate from PGI Chandigarh, a fellow in GI and liver pathology from University Health Network, Toronto, Canada. Presently, she is a consultant histopathologist in GI and hepatobiliary pathology in the Department of Histopathology, Gleneagles Global Hospital, Hyderabad, with multiple national and international publications. She is the national authority in liver transplant, and who better than her to discuss and have a slide seminar on her experiences on various liver transplant patients and pathology. Before I ask Madam to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Jyoti, ma'am, please share your screen and let us start. We are live. Just press present now, your entire screen, and you share your window. Yeah, that's it. I can see your screen coming. Yeah.
Okay.
Please share your PowerPoint from the. Yeah,
Okay.
please make it full screen. Yeah.
Okay.
And just press that hide thing so that pop-up just goes away. Fantastic, ma'am. Please start. Thank you.
Thank you very much, sir, for such kind introduction. So, in continuation with my previous talk on pathology of liver transplant, today I will be presenting some of the interesting cases in liver allograft period, that is post-transplant period. So, some of the cases which I am going to present today are the ones which are very common in allograft pathology, and some of the ones are uncommon ones. We will go through them one by one, and let's see how do we go. So, just a brief recapitulation of my previous talk. The biopsies in the post-transplant period are received either as a part of the protocol biopsy or event-driven biopsies. So the cases I am going to present today are the ones which are event-driven, that is, when there is elevation in the liver enzymes, the patient has certain signs or symptoms of liver disease, or any abnormality is detected on radiology. A brief recap of the various complications happening in the post-operative period, in the early post-operative period, late post-operative period. The highlighted ones are the complications which I'll try to cover in today's talk by showing some exemplary cases. So again, a brief recap that once we receive a liver biopsy in the post-transplant period, we must be aware of the following information which should be included in our requisition form, so that we get the information about the time after transplant, the indication of liver transplant, the status of immunosuppression, the liver enzyme trends, or any imaging findings if relevant. So with this, I'm going to start with my first case in today's talk. The first case here is a 55 years female who underwent cadaver-related liver transplant for NAFLD related CLD, which was decompensated with ascites portal hypertension. As a part of pre-transplant workup, viral serology was done, which was negative. And this is how we interpret the liver enzymes. So this is the liver enzyme trend for this particular patient, where we can see these are the transaminases. The AST, ALT are basically the hepatocellular enzymes. ALP, GGT are the marker for bile duct function. Whenever there is injury to the bile duct epithelium, these enzymes, they get elevated. And of course, bilirubin. So in this patient, as we see, on post-op day, the baseline liver enzymes, they were maintained well within the normal limits. This patient received tacrolimus-based regime, and she was maintaining immunosuppression. However, at 2 months of post-operative period, the liver enzymes and the cholestatic enzymes, they were kind of elevated. There was kind of gradual progression in the liver enzymes, and which was very significant at 3 months post-operatively, and at this time the biopsy was planned for this patient. This is the representative photomicrograph, where we can see this is the portal area, the periportal area. So the portal area, as we can see here, is markedly expanded due to many inflammatory cells. We see the portal vein here. We see the bile duct branch here, the hepatic artery branch here, again the hepatic artery here, probably a bile duct here. So let's see the nature of the inflammatory cells in this portal area. We can see that there are many these mature appearing lymphocytes which are darkly stained. Then there are these lymphoid cells, some of the lymphoid cells here, which are slightly larger than these mature appearing lymphocytes, have kind of vesicular nuclear chromatin, like here, and there are many scattered eosinophils. So by now, if you have heard my previous talk, you will get to know that this is the typical mixed inflammatory milieu which we see in cases of typical T-cell mediated rejection. This is the bile duct here. It is infiltrated by these mature appearing lymphocytes, causing the duct damage. The portal vein here, again we can see that these inflammatory cells, they are undermining the subendothelial space and causing uplifting of the endothelial cells. In addition, there is spillover of this inflammation onto the adjacent periportal hepatocytes, causing the hepatocyte damage. Also, we can see that there are these scattered foci of lobular inflammation, like here, then here. There is some hepatocytic damage caused by this lobular hepatitis. This is another portal area, high magnification. So here also we can better appreciate the nature of inflammatory cells, these mature appearing lymphocytes, these eosinophils, these blastoid or activated lymphocytes, which are larger cells. Again, we have this hepatic artery branch here, the bile duct epithelium. So here, if we see the ductal epithelium here, it is infiltrated by these inflammatory cells. Here, lymphocytes here, this darkly stained. And in addition, this bile duct is also showing this cytoplasmic vacuolation. So these are labeled as degenerative changes in the bile duct epithelium. This is a central vein branch, the hepatic vein branch, and we can see that there is a group of hepatocyte here in the perivenular area where there are foci of perivenular confluent hepatocytic necrosis, which is more pronounced in the zone 3. However, also there are some scattered foci of lobular hepatitis here and there in the zone 2. And also one can see the apoptotic body 1 or 2 which are scattered here. So summarizing the finding in the biopsies, we have this mixed inflammatory milieu which is typical of T-cell mediated rejection. We have evidence of bile duct injury. We have evidence of portal venulitis and perivenular hepatocytic dropout along with central vein damage. So there we have central perivenulitis. So this case was diagnosed as T-cell mediated rejection. Following the diagnosis, the patient was treated with pulse steroids. So these were the liver enzyme profile when the biopsy was done for this patient. After the diagnosis, the pulse steroids they were administered. Immunosuppression was increased. This patient responded well to the treatment for the initial 2 weeks after the administration of steroids. However, later on, the bilirubin levels they were started increasing and reached up to level of 14 a month after the first biopsy, which was 5 months in the post-transplant period. Remember, the first biopsy was done at 3 months, and first the patient responded well, but again the cholestatic liver enzymes they started increasing, and there was increase in the bilirubin levels. So at this time of the liver enzymes, a biopsy was planned, and these were the liver enzymes and bilirubin levels when I received the biopsy. So here again we can see this portal area. Here is the central vein, and this is the hepatocytic cord. So as we see here in the portal area, there are few scattered lymphocytes, lymphomononuclear cells, and it is restricted to the portal space. There is this bile duct epithelium, bile duct branch here. The lumen is kind of obliterated here, and there is loss of nuclei in one part of the bile duct here. Some of the nuclei look enlarged, and the cytoplasm, it appears hypereosinophilic. There is hypereosinophilia of the cytoplasm. This is called as senescent changes in the bile ductal epithelial cell. There is no evidence of portal venulitis. There is no evidence of central venulitis. Also in the parenchyma, we can see that some of these spindled nuclei, which are Kupffer cells, they are hypertrophied as a part of reaction, and we can observe the cholestasis within the hepatocytes and also within the canalicular spaces, like here. This is another portal area where again we can see this is the bile duct branch. Again, this lymphocyte, it is kind of infiltrating into the epithelial cells. There is uneven distribution of the nuclei, and some of the nuclei they are overlapping. Another portal area, not much of inflammation. The hepatic artery branch here, the portal vein here, there is no evidence of any portal venulitis. But if we see the accompanying bile duct branch here, it is showing cytoplasmic hypereosinophilia. The lumen is not well visualized. The nuclei they are lost. These are termed as senescent or atrophic changes in the bile duct epithelium. Just a representative photomicrograph of the lobular parenchyma. This is probably a central vein branch perivenular area where we can see that there is marked cholestasis in the canalicular spaces. So, summarizing the finding, we have significant senescent duct changes involving majority of portal areas in this biopsy, and we have cholestasis in the lobule. So, whenever we get such changes in the liver biopsies, one has to think of these possibilities in the post-transplant setting. In this case, the patient did not receive any drugs. Some of the common antibiotics like Septran, they are known to cause cholestatic liver disease and vanishing bile duct disease. This patient was not transplanted for PSC, so the question of recurrent PSC is out. And considering the history of T-cell mediated rejection, and this patient was already on treatment, in this case, this is a case of chronic rejection because of the typical morphological findings, senescent duct changes involving majority of the portal areas. So consequent to the biopsy diagnosis, Again, the immunosuppression levels, they were modified. Evergraph or everolimus, that was administered, and this is usually given in the early phases of chronic rejection rather in chronic rejection cases, and this patient responded very well to the treatment. And these are the liver enzymes 2 months after the biopsy, where the total bilirubin kind of normalized. So I have shown this case just to emphasize the histopathology of T-cell mediated rejection, which is the most common indication of liver biopsy in the allograft period. So just recapitulating what we have learned in the last class of pathology of liver transplantation, T-cell mediated rejection is the most common form of rejection, typically showing this mixed kind of inflammatory cells as we saw here, bile duct injury and venulitis. Once we make the diagnosis of rejection, we grade it according to rejection activity index system given by Banff Working group, and these patients, they respond well to steroids in majority of the cases. In certain cases, like 8 to 10% of the cases, they may not respond to steroids, and in such cases, certain other methods of immunosuppression like ATG, antithymocyte globulin, and other immunosuppressants are being administered. So this is just a brief recap of the rejection activity index, where we score each of these 3 components on a scale of 1 to 3, and we sum total and we find the rejection activity index to guide the treatment of these patients. Chronic rejection, this patient presented with cholestatic liver dysfunction later on, and this is how typically these cases present in the later allograft period or maybe in the overlap period. The important thing in chronic rejection is to define whether there is duct loss in majority of the portal areas or in few of the portal areas, and subgrouping them as early or late chronic rejection according to the criteria which are given by Banff Working group. It is important because if the patient is diagnosed in the early allograft period, they can be successfully treated with increased or modifying the immunosuppression regime. So with this, I am moving on to my second case today. This is a 20 years male who underwent living donor related liver transplant for Wilson disease. And this is the enzyme trend for this patient. So at the 2 months in the post-operative period, this patient, he was found to have anastomotic biliary stricture on cholangiogram. This patient was investigated because he was having this cholestatic pattern of liver enzymes which was kind of persistent right from the transplantation period, and he was found to have anastomotic biliary stricture. ERCP stenting was done in this patient. He was relieved of cholestasis during the initial 3 months, but later on he developed increase in the aminotransferases level as well as the cholestatic liver enzymes and also the bilirubin levels. So at this time it was the patient was diagnosed clinically as rejection, and Pearl steroids, they were administered. We can see here the liver enzymes, the hepatocellular enzymes here during the course from 2 months to 11 months, despite these events of biliary stricture or rejection, they are not of much elevated as are these cholestatic liver enzymes. They are quite fluctuating here, and so is the bilirubin levels. Initially the bilirubin levels was kind of steady, it was not rising too much. However, at 11 months of post-transplant, the patient had a bilirubin level of 25, and at this time it was being advised, the biopsy was being advised. The patient underwent liver biopsy to elucidate the cause of increased bilirubin in this patient. So here we see this is the portal area which kind of look expanded here because of many inflammatory cells, and of course we can at this power we can appreciate there are many foci of lobular inflammation. The high power view of the one of the portal areas, where again we can appreciate this mixed inflammatory milieu with these mature appearing lymphomononuclear cells, blastoid or activated lymphocytes, and the bile duct injury here. this is infiltrated by the inflammatory cells. There is also evidence of portal venulitis. This is another portal area. This portal area also looked expanded with this mixed kind of inflammatory cells with lot of lymphocytes, plasma cells, activated lymphocytes. There is evidence of portal venulitis. We can see that the endothelium here is hyped up, and we can see many neutrophils also here in the portal space, along with some evidence of ductular proliferation. There are these increased duct profile at the interface. Another portal area of the same patient, the inflammatory component is not as striking as we see in the other portal spaces, but here we can see that there is some epithelial damage in the form of epithelial cell necrosis, some infiltration by polymorphonuclear cells. They are present within the epithelium as well as within the lumen. Another portal area where we can see this sparse lymphomononuclear cells, probably some activated lymphocytes, and again there is presence of neutrophil within the lumen of this bile duct branch. Evidence of portal venulitis in this portal area. Another portal area in the same case, which kind of look expanded. The portal area is expanded with again these striking eosinophils, some blastoid lymphocytes, some mature appearing lymphocytes, some macrophages, and we see here the bile duct branch accompanied by the hepatic artery branch. We can see that this bile duct, it is infiltrated by some of the inflammatory cells, and also striking is this concentric lamellar edema or periductal edema, which is seen in this native duct branch. And also some of the ductular profiles, they are not so striking here, but yes, there were some ductular profiles at the interface. Another portal area where we can see the hepatic artery branch. But hello, here, what is happening? The bile duct here has vanished. It has completely gone. And we have this mixed inflammatory cells. We have some ductular proliferation at the interface. Same thing being highlighted on the Mason trichrome stain. We have the hepatic artery branch, the bile duct here has gone, completely vanished, and we have some evidence of bile ductular proliferation at the interface. And also in this portal area, we can see some evidence of portal venulitis. Now, coming to the lobular parenchymal changes. These were the changes in the portal area which I have already mentioned. So this is how the parenchyma looked in this case. So if we see here, this is the hepatic vein branch, the central vein, and these are the hepatocytes. There are many foci of these lobular necroinflammation, foci of confluent hepatocytic necrosis. We can see some cholestasis within the hepatocytes, intrahepatocytic, and there is evidence of some central venulitis. Another area from the same biopsy where we can see there are these areas of confluent hepatocytic necrosis, there are these scattered foci of lobular necroinflammation and cholestasis. So summarizing the findings in this case, in the portal areas we have varied morphological findings. We have this typical rejection type of infiltrate with evidence of portal venulitis and bile duct injury in some of the portal areas, while in other portal areas, apart from these changes, we do see portal edema, periductal edema. There is presence of neutrophils within the epithelium of the duct and within the lumen of the bile duct structures. And in the lobule, we have these evidence of perivenular accentuation of the inflammation, lot of foci of lobular hepatitis, confluent hepatocytic necrosis, and Kupffer cell hyperplasia. So if we just talk about rejection type infiltrate, the presence of periductal edema, neutrophil in the epithelium and in the duct, subtle ductular proliferation cannot be explained by rejection type of infiltrate alone. So there are two separate pathogenetic mechanism which are acting in this case, as this patient already had developed anastomotic stricture, if you remember, and this patient was being stented. However, the cholestatic liver enzymes, they kept on increasing in this case, and so was the bilirubin level. So this patient had two pathogenic processes. He had T cell mediated rejection and concomitant biliary injury which was going on in this case, and because of this progressive dysfunction of the liver allograft, progressively increasing liver enzymes which were not amenable surgically corrected by stenting and other methods, this patient was relisted for transplant, and he underwent transplant at our other center, Chennai center, and is doing well now. So I have kept this case to discuss the biliary stricture in the post-allograft period or in the post-transplant setting. The incidence of biliary stricture in the post-transplant setting, the incidence is more in cases of the patients who undergo living donor-related liver transplant as compared to cadaver-related liver transplant. And as we have already discussed in the previous class, and we see here also, in the early one we see neutrophilic predominant inflammation, portal edema, periductal edema, ductal proliferation, while in the later cases the fibrosis predominates and there is evidence of marked ductal proliferation in these cases. So this is about the histopathology part. Now coming to the pathophysiology. The stricture in the post-allograft period can be either at the anastomotic site or it can be within the liver parenchyma, that is in the intrahepatic bile ducts. So the anastomotic biliary strictures and non-anastomotic biliary strictures, they are important to identify. Whatever is the cause of or is the level of stricture, the histopathological features remain same. So because the distal to the obstruction, the histopathological features will be similarly identifiable in both the anastomotic and non-anastomotic stricture site. So there are different risk factors for the anastomotic and non-anastomotic strictures. In cases of anastomotic stricture, it is the poor surgical technique or there is even evidence of previous bile leak. In such cases, the patient can be successfully treated in most of the cases by stenting on balloon dilatation. The cases of non-anastomotic stricture, they have different risk factors related to the perfusion-reperfusion injury, prolonged cold ischemia time, related to hepatic artery stenosis, and they tend to be multiple and longer in segment and are intrahepatic in location. And that is why they are less amenable to therapy and have less favorable outcomes. In my case, which I have shown, this patient though developed anastomotic stricture pre and was stented, but later on cholangiogram, he was found to have multiple intrahepatic strictures, which is basically non-anastomotic stricture side, and that is why he continued to have cholestatic dysfunction and had markedly elevated bilirubin levels. So this is one of the other complication. Now moving on to the other case showing a different spectrum of complication. Case 3. Case 3 I am showing here is a 46 years female who underwent living donor related liver transplant for Budd-Chiari syndrome associated acute liver failure. This is the liver enzyme trend for this patient. The liver enzymes, they normalized after the transplant. However, the significant elevation in the liver enzymes was seen at 8 months post-transplant. The patient was not found to be compliant with the immunosuppressants and clinically was diagnosed as acute cellular rejection or T-cell mediated rejection. She was treated with pulse steroids and modification in the immunosuppressant regime. She responded really well in the 9th month, and as you can see here, then there was this increase in the ALP levels, and at this point of time, because of increase in the bilirubin levels also, in between 9 months to 17 months, the liver enzymes, they dropped down, which I have not shown here, because of the elevation in the ALP and bilirubin, and she had some symptoms. The cholangiography was done. She was again found to have anastomotic stricture, for which PTBD was done. And then on follow-up, she developed again itchiness. and there was marked elevation in the hepatocellular enzymes and bilirubin levels as we see here. So it is hepatocellular predominant enzymes we see at 18.5 months post-transplant, and this is the time when biopsy was planned for this patient. This is the representative photomicrograph where we can see this is the portal area, this is the central vein, lot of inflammatory cells here. This is the high power view of this portal area. We can see that the portal area here is irregular. There are many inflammatory cells which are composed of these mature appearing lymphocytes, some of the plasma cells, and there is significant interface activity. That means these inflammatory cells, they are spilling onto the periportal hepatocytes, causing the periportal hepatocytic damage. The bile duct here looks pristine. There is no evidence of any bile duct injury. No significant portal venulitis here. There are these scattered foci of lobular necroinflammation, and the Kupffer cells here are prominent. Another portal area. Again, we can see that the bile duct here is pristine. There is no evidence of bile duct injury. The portal vein also looks normal. Not much of portal venulitis, and again we see that there are these lot of inflammatory cells with lot of interface activity damaging the adjacent periportal hepatocytes. This is the high power view of the interface inflammation. Here is the interface, the hepatic artery branch. These are the periportal hepatocytes. This is to examine the nature of the inflammatory cells. These are mainly plasma cells, as we can see with eccentrically pushed nucleus. So this is the representative photomicrograph from the central vein branch here, hepatic vein branch. The diameter of the hepatic vein, it looks compromised. It is not circumferential as we see in most of the portal of the central veins in normal biopsy. The lumen looks compromised. There is evidence of perivenular hepatocytic dropout, and then there are these scattered foci of lobular necroinflammation. This is another hepatic vein branch in the same case, where we can see that the lumen here looks compromised and there is extensive necrosis of the perivenular group of hepatocytes, and this is mediated by very striking presence of many plasma cells. These are all plasma cells. So summarizing the histopathological findings in this case, we have the portal inflammatory component being composed predominantly of the lymphomononuclear cells admixed with plasma cells. No activated lymphocytes, or not the typical inflammatory milieu of typical T-cell mediated rejection. So in this case, we have also prominent central perivenulitis mediated by many plasma cells. So in such cases, in the later post-operative period, when we see a lot of interface activity, lot of perivenular inflammation, central perivenulitis with many plasma cells, one has to think of these following possibilities: the plasma cell-rich rejection and recurrent autoimmune hepatitis. This patient, she was transplanted for Budd-Chiari syndrome. She was JAK2 positive, and hence the possibility of recurrent autoimmune hepatitis was not considered. So I considered a possibility of plasma cell-rich rejection. Going by the criteria which was given by the Banff Working Group in 2016, these are the criteria to establish a diagnosis of plasma cell-rich rejection, where there is presence of portal or perivenular plasma cell-rich infiltrate, which is comprising more than 30% of the inflammatory component with significant RAI score, rejection activity score. Also, the original disease must be other than autoimmune hepatitis. So this criteria 1 and 3 are the absolute criteria, and most of the cases of plasma cell-rich rejection, they fulfill these criteria. Lymphocytic cholangitis, it is a desirable criteria, however not absolutely required to establish the diagnosis. Also, the Banff Working Group has recommended and advocated the role of C4D stains and IgG4 stains in these cases. So going by these criteria, I did IgG4 immunostaining, and this is the IgG4 immunostain. Here we can see that this was the focus of interface activity, which was mediated by many plasma cells, and many of these plasma cells, definitely more than 25 per high power field, they are positive for IgG4. The C4D stain, we can see here, this is the portal vein. There is a lot of background positivity, just ignore it, disregard it. So in the portal vein, there is linear positivity, which is definitely occupying more than 50% of the circumference, luminal circumference. So we have C4D positivity here. We have IgG4 significantly positive plasma cells at the interface. So a diagnosis of plasma cell rich rejection was rendered in this case. Following the diagnosis, the patient responded very well to pulse steroids. As we can see here, there is marked decrease in the bilirubin levels, and so are the enzymes level within a month of liver biopsy. So this case I have put here because this autoimmune hepatitis or plasma cell rich rejection, which was also called as de novo autoimmune hepatitis before, it is a special form of rejection, and these two entities, they share a lot of clinical features, their biochemical enzyme pattern. Also, there may be positivity for autoantibodies in cases of plasma cell rich rejection. However, there are certain other features which delineates these two entities, and there is a different pathophysiologic mechanism for this type of rejection, which is kind of not completely understood as of now. Some of the salient features I have quoted here from this particular article. The number of IgG4 positive plasma cells, they are more in cases of plasma cell rich rejection. There is more prevalence of lymphocytic cholangitis in cases of plasma cell rich rejection, and one may see C4D positivity in the portal microvasculature. This is a recent study which I have just quoted here. So people are trying to identify the pathophysiologic mechanism for this plasma cell rich rejection in liver allograft patients, and this is one of the landmark study where the cellular profile of these cases, they were extensively studied, and it was found that these are the T cells and plasma cells which were kind of predominant in the rejection biopsies, which were diagnosed as plasma cell rich rejection, and many of them, they were positive for IgG4, as we see here. So that was a case of another form of rejection which is seen in the later allograft period, the plasma cell rich rejection. It is not a common form of rejection. Now moving on to another case. This is a recent case. Okay, yeah, so this was a 17 years female. Right now we have this patient in our hospital. She is interesting case who underwent living donor liver transplantation for bile acid synthetic defect, which was genetically proven. And this patient, a month after transplant, she developed ascites and was found to have portal vein stenosis at the anastomotic site. The stenting was done in the portal vein, the flow was established. This patient, she was doing alright till a week after portal vein stenting. However, later on, progressed to have ascites and features of portal hypertension in the form of melena, hematemesis, and at this point of time, the liver biopsy was being performed. This is the representative photomicrograph where we can see that the striking feature of the biopsy here is lot of congestion, lot of sinusoidal dilatation and areas of hemorrhage. This is the central vein branch here. Again, this is the hepatic vein branch, the central vein, and there is lot of sinusoidal dilatation and congestion with areas of hemorrhage which are accentuated in the, which is kind of panlobular here in this field. Here there is a portal area, we can see the bile duct branch. Another area where we can see this hepatic vein branch and lot of congestion, hemorrhage happening in the perivenular area. Another, a larger branch of the hepatic vein. we can see that there is some thickening or edema in the hepatic vein branch here, along with lot of congestion in the perivenular area. This is the portal area which was seen in this case. We can see there is a bile duct. The bile duct looks normal. The portal branch here, the portal vein branch here looks attenuated. Normally in the liver biopsy, we expect the caliber of portal vein to be at least 3 to 5 times the caliber of the bile duct branch. We see here in this biopsy, the lumen of the portal vein is compromised. So there is some obliteration in the portal vein branch, which is more pronouncedly seen in this Mason trichrome stain. There is some portal fibrosis, the thick bands of fibrosis, and there is some compromise in the lumina of this portal vein. As we can see, there is a lot of congestion. This is another portal area of the same case where we can see that the hepatic artery branch, it is well maintained. The bile duct branch here is not well visualized, and so is the portal vein branch. Not much congestion in the periportal area. Another portal area where we can see the hepatic artery branch, the bile duct branch, and again the portal vein branch, it is attenuated in caliber. Bands of fibrosis which are highlighted with this Mason trichrome stain. Another portal area of the same case where we can see that the portal vein here, the caliber is reduced, and there are these megasinusoids in the periportal area. The areas of congestion, they are accentuated distant from the portal area, that is more pronounced in the zone 3 and zone 2 areas. Summarizing the findings, in this case, we have lot of sinusoidal dilatation and hemorrhage, with accentuation in zone 3 and zone 2, and panlobular in some of the areas. We have mild intimal edema in the hepatic vein branch. Whenever, even in native biopsy, we see zone 3 sinusoidal dilatation and congestion and hemorrhage, we raise a possibility of hepatic venous outflow obstruction, and so did I. I raised a possibility of hepatic venous outflow obstruction in this case. And since the portal vein caliber, they did not look normal to me, I also raised a possibility of possibly obliterative portal venopathy in this case. CT angiography was being advised. And these are the axial planes of the CT images. Here we can see that the portal vein, in the portal vein, the stenting was done in the early postoperative period. It is well placed within the lumen of the portal vein. This is the liver, and here we can see this part of the liver, it looks hyperdense, and this is the branch of the middle hepatic vein which looks okay. However, if we look at this area of the liver in comparison to this area, this looks hypodense. Again, in the other plane of the same axial sections, we can see that the left hepatic vein, it is tapered here because of obstruction, and that is why there is this hypodense area which marks the congested area, as we see on the biopsy in this case. So following the diagnosis, in this case the hepatic vein was stented, but this patient continued to have ascites, and recently, this was very recent in the last week, the pressure gradients, they were checked in this patient, and the findings were suggestive of portal hypertension. I still believe this patient has some element of obliterative portal venopathy. As we see in the portal veins, they are attenuated in caliber, obliterated in caliber. So I still believe there is an element of obliterative portal venopathy. Only at the follow-up in this patient, probably we will come to know what exactly is happening in this patient, as this patient continued to have ascites despite being stenting of the hepatic vein branches. This hepatic venous outflow obstruction, it is a very rare complication in post-liver transplant setting, and it may be related to mostly related to the anastomosis, Some certain drugs may be implicated, and in certain cases where central perivenulitis is the major form of rejection pattern, in those cases, rare situation, veno-occlusive lesions may develop, and in this patient, outflow may be compromised. Regarding the presence of obliterative portal venopathy, which I suspect to be present in this particular patient, this is a very rare complication in liver allograft period. As I was looking through the literature, I could identify very few case reports. This is a recent one where they have described obliterative portal venopathy in 4 pediatric patients, and these patients, they were found to have chronic antibody mediated rejection and DSA type 2. In all the 4 patients, they have described to be having obliterative portal venopathy. But these cases which they have described to have this particular complication are in the later allograft period, that is after 2 years. So in this patient, I can't really pinpoint what is the cause of obliterative portal venopathy, but I still believe it is there, and maybe in next few days the liver biopsy will be performed, and we can see exactly what is going on in this patient contributing to ascites even now. Moving on to the last case of today's session, that is the case number 5, which is yet another complication. Okay, so this is a case which I also presented in Indian Society of Organ Transplantation 2018. This is a 58 years male, known case of diabetes, who was referred for NASH-related decompensated cirrhosis, and as a part of protocol workup, in the pre-transplant period, this patient was found to have detectable HCV viral load in 3 logs. This patient underwent abiocompatible cadaver-related liver transplant and was maintained on routine immunosuppression. The ischemia time, both cold and warm ischemia time, they were within normal limits.
Hello?
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 Yeah. Sorry, sir. I apologize. I
No,
didn't
no,
know I
no,
was going on and on.
no issues, actually, no problem.
So, where should I start from? Like from this fifth case?
Yeah, just start from the beginning of the fifth case. I mean, I think that's exactly where we lost the entire connection.
Okay.
No,
Really
just start.
apologize. Yeah.
Not your problem. I mean, it happens.
Thank
No
you.
issues. Just start from here. Right, no issues.
Yeah. Okay. The fifth and the last case of this session. This was a 58 years male who was referred for NASH-related decompensated cirrhosis, and as a part of pre-transplant protocol workup, he was found to have detectable HCV viral load in 3 logs. He underwent ABO-compatible cadaver-related liver transplant. The cold and warm ischemia time they were maintained within the normal limits, and the patient was maintained on routine immunosuppressants, TAC-based regime. So this is the liver enzyme trend for this patient, where we can see that the liver enzymes, they are fluctuating right from post-op day 1 and continue to have fluctuating liver enzymes till day 11. However, the bilirubin levels, they were steadily increasing and progressive in nature. We can see that on day 1 they were 4.67, increasing up to 10 at day 11. Though the liver enzymes, they kind of coming to the baseline, but the bilirubin levels, they were steadily increasing in this case. So a liver biopsy was done at post-op day 11 with a clinical impression of rejection. And this is the representative photomicrograph, where we can see this is the hepatic vein branch, this is the portal area. We can see here that there is panlobular hepatocytic swelling. The hepatocytes, they look swollen. The hyper view, where we can see that these hepatocytes, they are rounded. There is cytoplasmic rarefaction and ballooning. So these hepatocytes, they are all bloated up or ballooned up. This is a portal area where we can see there is some evidence of ductular bilirubinostasis. And here we can see that there are some scattered apoptotic bodies, and there is significant cholestasis, both canalicular as well as intrahepatocytic. Also, in addition, what we notice here are these abnormal nuclei which looks distinct from the adjacent nuclei. In what sense? There appears to be some margination of the nuclear chromatin, there is some multinucleation, there is some molding of the nuclei, and so is the bilirubinostasis as we see here. This is another area of the same biopsy where we can see these nuclei which are kind of infected by the viral inclusion. We can see that there is margination of the nuclear chromatin, there is multinucleation here, and there is molding of the nuclei. And there is hepatocytic damage which is going on in these areas. Probably some neutrophils are coming up and infiltrating this area. So we have this characteristic inclusion of herpes simplex virus in this case. This is the Mason trichrome stain showing these bands of fibrosis which are kind of going from the portal areas into the periportal sinusoidal spaces. Another photomicrograph where we can see these bands of fibrosis on the Mason trichrome stain. They are insinuating into the adjacent sinusoidal spaces. So very straight away we see these inclusions which in pathology we have margination, molding of the nuclear chromatin and multinucleation, quite suggestive of herpes simplex virus inclusions in this case. We have this HSV associated hepatitis in this case. But this HSV hepatitis, they are characterized by these areas of neutrophilic microabscess or punched out necrosis in the liver biopsy. In the background liver parenchyma, we have this diffuse hepatocytic swelling, some perisinusoidal fibrosis which is going on in this case. So I also suggested a possibility of cholestatic hepatitis, probably fibrosing cholestatic hepatitis in this case. Following the diagnosis, the patient was treated with IV acyclovir, the immunosuppressant levels, they were reduced. However, this patient continued to have some systemic complications, and he succumbed to multi-organ dysfunction syndrome on day 15. So in the follow-up investigations of this case, the HSV1 was detected on qualitative PCR. The serology for HSV1 and 2, both IgM and IgG were negative. The donor sera was not available for investigation in this case. HSV-associated hepatitis in post-transplant setting, whenever it is happening, either it can be because of the reactivation of the latent virus, or it can be due to de novo virus. So to differentiate between these two, the serology helps in this case. In our index case, the serology for IgM and IgG, HSV1 and 2, they were negative, and the donor sera was not available for testing. So presumably, this HSV reinfection must have come from the donor sera. In the post-transplant setting, HSV hepatitis, whenever it occurs, it is a very uncommon but a very fatal form of liver allograft complication happening in the early post-operative period when the levels of immunosuppressants are at peak. And they are characteristically identified on histology by areas of punched out necrosis and the characteristic inclusion. And they have very poor outcome or fatal outcome in most of the cases. I also suggest a possibility of fibrosing cholestatic hepatitis in this case because of the presence of the characteristic morphological findings in the form of this panlobular hepatocytic swelling. There is cholestasis, which is ductular, both canalicular, and this patient, remember, had 3 logs of HCV viral levels in the pre-operative period, in the pre-transplant period. So these HCV group of viruses, they are known to interact with herpes group of viruses and can cause infection in a can interact with each other and can cause a very aggressive infection leading to the early allograft dysfunction in post-operative period. However, in our case, the HCV loads, they were not done in the post-transplant period because the patient succumbed really fast in this case. And this is how they behave when this fibrosing cholestatic hepatitis happens, and that too along with herpes group of viruses. And in this case, it is HSV1. So these cases, they succumb really fast, and we may lose these patients if not if not recognized very early in the liver allograft period, and if the index of suspicion is not really high. So with this, I conclude today's talk.
Thank you so much. Wonderful.
Yes.
Very, very interesting cases, especially the last one was the topping on the cake. I mean, HCV, HSV, both together, my God. And the best part of your talk, Dr. Jyoti, has been that not only have you showed the cases, but you have been very much internally teaching us on those cases as to what to be seen and how do we come to a diagnosis. That is so nice of you. And very, very interesting cases, the very simple ones, the slightly difficult ones, and then the later last two was quite difficult, and the obstructive part, and as well as the double virus infection.
Yes.
These are all eye-openers for all of us, and as I think new centers start up the liver transplant pathology, we all would be seeing more and more things, and we'll be learning. Yes. And I think many of us will have to go back and see both your class as well as your seminar together to learn the subject well.
True, sir.
Thank you so much. You are really an expert in liver transplant pathologies.
Thank you very much,
sir. It's nice to know that there is somebody whom we know who's an expert, and we can refer our patients to you. Thank you so much. God bless you. Thank you so much.
Bye.
Take care. Bye-bye. Take care. Bye.